Sonet anasema hello radio generation. Timbuvi, Rastas are generally vegetarians following the diet as outlined in Leviticus. They tend to avoid meat and dairy products. You know what? We actually have a doctor here in studio. And we are here to talk about some of these issues, including cancer.
Paul.
Yes.
We have with us in the studio a medical doctor.
Yes.
Madaktari ni wengi, miti shamba ni daktari.
Sasa
ni daktari.
Unajua nilikuwa naenda kumintroduce vizuri. Nimesema we have a doctor in the studio. Hata sijasema jina yake, but he was here last week on Friday it was, yeah. We spoke vastly about extensively about diabetes. It's Dr. Daniel Katambo, a consultant physician and founder and CEO Afyacode and Clinic Reversa. So, karibu sana daktari once again.
Asante sana for having me once again.
Ulitu-promise utarudi na umerudi.
Nimerudi, asante sana kwa kunialika.
Politicians wanasemanga, nitakuja.
By the way,
2 months later bado wapati kwa simu.
This is you're back by popular demand. People wanted you to come back.
Yeah.
Let us just tell you.
Yes. Thank you.
The listener said, please bring that gentleman back, please, and bring him quickly so that we can yes, so that we what he's saying makes sense. We want to understand it better, please. Yes.
So daktari, karibu sana.
Asante sana.
Umesikia hiyo comment nimesoma hapa ya Rasta. Nilikuwa nauliza mbona wa Rasta wengi wanakuanga tu wanatoshana kama wewe actually. Very few, you'll find very few Rastas wanatoshana kama mimi. Yes. And now a viewer here, sijui kama yeye ni Mrasta, anasema most Rastas are vegan and depend on ITAL diet. And so that is saying they follow they are generally vegetarians following the diet as outlined in Leviticus. They tend to avoid meat and dairy products.
Yes.
So Leviticus, I don't know if you're a Christian and if you know about Leviticus, but is there a diet in Leviticus?
Hiyo ni swali ngumu. Ungeuliza kama nasomanga Biblia.
Unasomanga Biblia?
Nilikuwa nasoma.
But so apparently we'll find that diet in Leviticus. Yes. But when someone is vegan, does it mean that they'll never grow, fat?
There are two aspects to look at it. When you become a vegan, what do you mainly consume? And what is your activity level? Remember what we discussed last week?
Yes.
And what contributes to people developing type 2 diabetes. And I'm sure when somebody says about the vegan, probably they're thinking about type 2 diabetes. Now, I'll give you some aspects of diet. So what or the definition of vegans, because it's good for us to understand. When somebody does not consume meat, that's a vegetarian. They still can take maybe eggs. They can still take some meat products, but they don't take nyama yenyewe. Utapata hiyo, they are not very keen on taking nyama yenyewe.
Dairy products?
Na dairy products pia wanachukua dairy products when it is when it's vegetarian.
Okay.
They also consume lots of beans, lots of grains and vegetable curries, such like stuff. But a vegan goes deeper and says anything that is either harvested or coming directly from an animal, I will also not take it. So they don't take dairy products, they don't take eggs, they don't take, and they totally become dependent on vegetables and starch. Okay. Now I will tell you for a start. Number one, these guys depends on what you do. Number one. Number two, remember, Rastafarians are not vegans, all of them. Maybe this one was an exception. We tend to get them being a mixture of everybody. But again, remember, Rastafarians are also very active. If you know them, maybe you remember Bob Marley. He used to be quiet. Yaman used to be very active. If you look at Jamaicans that put those, they are actually herbivorous. They really consume a lot of nyamas. They consume a lot of meat and vegetables mixed. To answer specifically to this question, we really need to think about what causes somebody to go or gain weight.
Okay.
And you will find it is a fact that you consume these things called carbohydrates that makes you gain weight. Not everybody does. But if you consume excess of this stuff and your activity level is really low, then this contributes to you gaining weight. If you are vegan you're consuming more and more. In fact, you've moved from the things that make you lose weight or not lose weight to the things that make you gain weight.
Okay.
Now look at the communities, for example. You know the Indian, the Indian community in Langata. You know that just upper carnivore.
Okay.
There's a whole Indian community that I don't know what it's called.
I know the temple that is there, but yes, I know there's a community there.
There's a community there.
Yeah.
I will surprise you. And there's also another community of the Sikh community around the Sikh community around Ngara, somewhere there.
Our Guru Nanak.
Yes, around there. I'll surprise you. There's a time I did a small survey to look at
their diet,
and the rate of probably obesity, hypertension, and non-communicable diseases. In Kenya, the average is about 3 to 4% of those numbers, and in that community, it's about 18%. So the perception that vegans and vegetarians are better off in terms of cholesterol issues, in fact, and obesity, type 2 diabetes, and blood pressure issues is not true.
So you're saying that the Sikh community, their diet is vegan?
They are vegetarian mixed, so you get some of them that are vegetarian and vegans.
Okay.
The strict vegetarians tend to be overweight and obese.
What I know is that they avoid cow products from cows. So that's beef and milk. So anything cow they will not take.
Even chicken. If you are vegan, vegans don't take meat.
Oh, so them they are 100% vegan.
Yes, they become vegans.
I didn't know
don't
that.
Take. Vegetarians have those exceptions. So in vegetarian you have a bit of some meat here and there. Unaweka kamayai, unasema I eat the white kuku or the white meat only, and not even the.
So they don't even do fish.
No.
Hey. Okay.
Yeah, they can they can be very, very strict, and they can be, and when they come to the office,
yes,
and now you're trying to advise them on what to eat. Remember, I'll give you an example. For example,
okay,
who are Maasais? And what do they consume most?
Pastoralists. They like their cows, so they take a lot of the milk, the blood, the meat.
And the meat.
Yes.
If we compared the Maasais and the vegans or the vegetarians, who has more diseases?
Hapo sina stats, sitakudanganya.
It is the vegans, and the vegetarians. Yes.
Okay.
And remember, when the first reversal and remission of type 2 diabetes was done, it was actually done here in Maasai land. People came from California and studied us. Do you remember the other time we were talking about city, and he was talking. He was asking me whether we do research.
Yeah,
I told him we don't.
It is done by others.
It is done. People just came and looked and said, "These guys, how come they are so fit? They walk, they drink their milk, they drink their blood, they eat their meat, and rarely take these starchy foods, and they do well. Actually, if you look at Maasais, they have less cholesterol, they have less diabetes, they have less communicable diseases if you studied them. Wachana nao wenye wamekuja town, wenye Narok na a bit of some Kajiado guys nikaangalia wamekuwa introduced to the good city life. These ones also develop the conditions that we are having. So it highly depends, because you will also get somebody else who lives in somewhere where, like for example, in Kenya, central area. If you look at central area, what do they consume the most? Wako na githeri.
Yeah.
And remember last time we talked about githeri,
yes,
we said the beans have about 60 to 70% carbs.
Okay.
The maize itself is also what?
100% carbs.
Exactly. So githeri, if you ate it nicely, and you also came from central, what do you add?
Unekanga avocado.
Viazi.
Viazi.
Unaweka viazi juu.
Okay.
And what else do they add?
Cabbage.
Cabbage na carrots. So by the time you are living there, you have really consumed a lot of
carbohydrates.
Yes. And then now look at what they do. What do they do? If you go to Central,
Central
now it's heavily populated. The shambas have niseme zimekuwa zimeshirang kama zimekuwa
they've shrunk with time. The holding per family has become smaller and smaller and smaller.
Exactly. So it is you and your house now, and nothing much of activity. And with all this supply of food, now that leads to quite significant amount of obesity, communicable diseases in those areas. Okay. So we can actually map diabetes according to communities in Kenya and according to what they eat.
Okay.
Again, furthermore, even when you go to Mombasa,
their staple diet now.
Yes.
Okay, Mombasa. Tell us
if you go to Mombasa, what do they consume?
Samaki.
Samaki umeanzia chini. Mihogo na nini? Mahamri sasa. Mahamri, mandazi. Kaimati kabisa.
Vitumbua
pale Mama Ngina Drive. Kuna meza nini?
It's called mbaazi.
Si ndio, kuna mbaazi pia.
Yeah.
Kwani kitumbua si vitumbua vinauzwa huko pia?
Yes, vinauzwa. Those are starches.
Yes. And now look at that population. If you look at Central, now the next community that is heavily affected by non-communicable diseases is the coastal area because of exactly what they consume. The Swahili guys
dishes,
the Swahili dishes also have a lot of
chapati.
Once you just find that community, then now you will be able to map out exactly
the diseases.
Wacha tuongee juu ya community yako.
Okay, Wakamba.
Wako na diabetes ama hawana?
Tuko nayo.
Iko.
Actually, I have several relatives who are suffering from the disease.
Exactly. But I will tell you that number is significantly fewer than Central. It's significantly fewer than Mombasa. And it's also significantly fewer than Western.
Are we talking about percentages here?
Yeah.
Okay.
We are looking at percentages. Because if you're looking at now an home or an area or an individual, then dynamics kind of slightly change because remember we talked about lifestyle and who and what you do to yourself that significantly changes your environment and hence subjects you to communicable diseases.
Okay.
So this is very important. If you look at Kambas,
Mudokoi.
They eat mudokoi, but if you look at them, they are still digging. There is one community that is still suffering and going to look for water. I am one of them.
Unanjua zile mashinda tuko nazo.
Mashinda ni nyingi.
Hai my brother, yani kumbe unaelewa hii ni shinda ambayo tuna.
Ukienda kuchota maji bado turembo twetu bado tunaenda kuchota maji.
Tunaendanga great distances.
Great distances. Without Google map.
So what is ailing us in Ukambani?
Poverty.
And that poverty is probably the same here also. You don't have the wherewithal for luxury.
Ukiona tulipeleka ng'ombe 100 jana kwa Raila. Na tulitembea nazo kutoka Kitui. Long distance training. So you're saying that the food we are eating in Ukambani is not a problem as opposed to the rest of the country?
Even if we consume githeri or you consume ugali, we tend to relatively be more active than another community.
Okay, as we search for water.
Exactly. Okay. That's what I'm looking about, and that is what relatively protects us. And you find the same. So, for example, I don't know whether it was here, whether it was City was asking me whether if you consume probably because I could eat githeri, right? Or eat a certain proportion of starchy food, but I'm active, you see. And then Buvi eats the same amount of food, same amount of calorie intake, but then you finish the whole day seated.
I'm very sedentary.
Very sedentary. This is two different people in this scenario, and because now we can't really change per se our activity level, it's very important for us to look at what we are consuming to relative, like for example somebody like Mbuvi now, what I can advise him, because I can't advise Mbuvi we wacha kazi enda ukakimbiange urudi Kitui uendange ukakimbie, maybe you will be very tired. If you go to the gym and you're still not doing checking on what you are eating and you're coming to sit here, that will only help about 5 to 10% of what you'll be doing. So food contributes almost 80 to 90%
Yes.
of non-communicable diseases. It's very important to note. Yes.
What is the correlation between what we eat and cancer?
Oh, very good question. Now, the one thing that has been always correlated with is what you eat and cancer. You've seen me pause, and it's because it is exactly a correlation. Now, in medicine, correlations are not causative.
Okay.
You understand? So I could say, I'll give you a typical example which people understand. For example, it's not cancer, but it's a good example I can use. Because people have cholesterol issues, right? We tell them not to consume eggs. So we say, in our popular understanding, that eggs cause cholesterol issue. Do you know that's not true? It is because we know studies that have correlated with eggs to cholesterol.
Okay.
But now if you look at clinical trials that now we depend as evidence, then there is none. There is no clinical trial that has been done properly that links eggs to cholesterol. You understand what I mean? And I think this is where the category for especially meat, for example, when people say meat causes cholesterol, I mean causes cancer. Then I ask myself, where is this study? Where are these studies? And then I go quickly into Google, Scholar, where we get everything, you check, and you find actually eating meat has never been shown to be a causative agent to cancer.
Right.
So I must put that out. But we always say in medicine, where there is smoke, there is fire.
Okay.
And because of lack of this vivid clinical trial on diet, and I will tell you why weakness comes when it comes to diet studies, it is very hard to keep a control. What I mean is, for example, if you came here and I said, let's all of us go and eat eggs and eat this type of food for the next 10 years or the next 1 year, it is very hard to control that bit. So nutritional studies and causative effect to really keep that clinical trial A, B, and C is very difficult. But it's easier for us to get 10,000 people and ask them because they have cholesterol issues. What did you eat?
Eggs.
In the last 10 years, I was eating 2 eggs. I was eating meat. So I was eating red meat. So I have breast cancer. I have prostate cancer. I have some cancer or some form of something.
So we say that all these people, what they have in common is the eggs and the red meat and the... Okay.
Thank you. But in terms of causative, we've not really...
Hakuna connection pale.
Exactly.
Okay.
Yeah.
Because there's some cancers, for example, colon cancer.
Yes.
Yeah.
Yes.
Where, it is said that perhaps eating these foods, like, for example, the red meats, there's a high chance that you might, get colon cancer because...
Yeah. It's exactly the explanation. Some cancers, breast cancer, so when you look at 5,000 people and you ask them how much meat were you eating in the last
10 years.
10 years.
They tell you half a kg every day.
Yes, and maybe another one for colon cancer got and said another maybe said another half a kg. And then we look at this population and say maybe these guys have colon cancer because of 1, 2, 3. But now if you looked at any clinical trial, when you say cause, let me tell you, when you say cause is if I smoke, smoking has been linked to small cell cancer of the lung. We know it causes, it is a cause. All clinical trials that have been done show that if you smoke, then you get lung cancer. So there is a direct link.
So this is empirical evidence.
Yes.
Okay.
But now there is no empirical evidence to what really causes colon cancer. We know the genetics behind it. We know there is a lot of association. But what really causes these cells to misbehave in this way, and another person they don't misbehave in that way.
Okay.
And this person they cause cancer, and this other person they don't. This is a place where, for our listeners, I really want them to know that it is not obvious that meat has been linked to any form of cancer.
Okay.
You see, there's this the discussion about meat, specifically red meat. I hear it quite a bit, and there are people who swear by white meat as opposed to red meat, and they say studies have shown. They are never quite able to tell you which studies.
Yes.
But anecdotally, you take a community like the Maasai, if I may do so, who eat their diet is predominantly meat, red meat.
Yes.
But then there's the other question. The research that was done on meat, where was it done?
Here in Kenya.
Precisely. And did they find, again, the causal issue, that these people whose diet is predominantly meat are predisposed to these ailments that people say are linked to eating red meat? See?
Yes.
If I talk of red meat that people eat in the areas we call the West, that meat is very different from what we eat here.
Very, very different. Actually, I didn't want to get into this topic.
Please do.
No. I am deliberately getting onto it because there are people who talk about it knowledgeably, and when you have a doctor, a medical doctor, it is good that we talk about it so that one at least gets an idea of how to look at these issues. That's why I've said that red meat, those cows, what they eat there, what we eat here, completely
it's very different. And remember, I was avoiding this, but I will touch on it.
All right.
Out there, food is really GMO, genetically modified, whether organism, whether plants, whether animals. Whether all this stuff. And I don't want to say that this is actually some of these things we have used them for treatment of diseases like cystic fibrosis.
Okay.
We treat them by genetically modifying our genetics.
Yes.
Because that's exactly what we do. And that we do not know. Honestly, we can't say we have concrete evidence on how this goes in terms of food. But now I can tell City, there's a lot of association of foods with some cancer. I'm saying association, but no causative. But I'm thinking in the next maybe 10 years, we might really be able to say maybe a certain form of nyama causes a certain cancer. But for now, the evidence is not as much. But there is GMO that are coming in, foods that are resistant to, pesticides, microbes, and high yield, and all this stuff. That for sure it's very new. Although it started out there, Katambo sana, it is very new in terms of nutritional research.
When we look at some of these GMOs, some of the genetically modified foods specifically that we consume, the plants that are grown, the seeds that are grown, like you said, some of them are resistant to pests. And they actually repel this particular pest. So you find like even like BT cotton, biotech cotton, that one is resistant to the worms, and that is why it is very high yielding, right? Now, coming to the foods specifically, just how, in your opinion, this is just you as and not necessarily as a doctor, just as a Kenyan, as an individual. Are GMOs bad?
If you ask me honestly, they are not. We just need regulation. We just need to make sure that you ask my opinion. Yes, I'm asking
for your opinion. And I know, of course, you're a scientist, so you'll be biased. But
I'm totally biased in this case. But I will tell you for sure. For me, I think if there is science and you can change something for the betterment of the community, then it's fine in where I sit. And I'll tell you, because I see this form of modification in diseases. Is that I've given you an example of something called cystic fibrosis.
Right.
Cystic fibrosis is a disease that you develop and you are your cilia, when you cough unatoanga mate, there's cilia in your trachea that helps those. I don't know, unaonanga tu filament tudogo
for the sake of the listener, tunywele tuko ndani
ni kama tunywele tudogo kabisa. That motility is aided by some genetic some gene in your of course nucleus that helps do that. So when you have cystic fibrosis, this motility is impaired. So everything is, you can't clear stuff up properly. So you get pneumonia all the time.
You're congested
all the time. When it comes to sperm production, you produce sperm, but then it can't
swim.
It can't swim to your urethra. So if now I said I don't like genetics, and yet we have treatment where somebody can modify that gene,
get gene therapy.
Exactly, get gene therapy, and when they are born, they do not have this disease, despite the fact that we knew they could develop this. Could we say we are not going to give this treatment?
No.
That is how I look at it. That's how, from where I sit, I extend the same to plants. So if we have a worm that is in Ukambani that has been eating mbemba siaka tumani,
you modify the mbemba.
You can modify, and people just make sure that they harvest more. You know.
You know the
Bemba is beans.
I do know, but yes. The commercialization that comes into the things we eat often are the problem. Because when you get big pharma, it's not as though the pharmaceutical problem, the pharmaceutical industry produces things which are problems. But the commercial element that we then now refer to as big pharma is the problem.
I agree.
The things they introduce so that the profits go up and what have you. So it muddies the waters completely, and we actually forget that the products that they're actually producing are actually good for us and actually benefit us. Now, when it comes to food, we're even more sensitive. Because when you look at, say, if I mention names like Monsanto and other big people who are in GMO foods, because of the great push they have towards cornering that market and being the big players in it, what they then do to ensure that that is achieved is what comes to the fore, and it's what people resist. And since it is food, you immediately attach it to GMO and you say
very quick.
This thing is a problem. And it has nothing to do with the science of that particular food. Nothing. None whatsoever. Okay? But if I leave that topic slightly and I look at something very fundamental with our food, things like fertilizer. Foods are sprayed with fertilizer. Some are into the ground. The science of what happens to the soil, the acidity that is formed, the science that we now hear of what happens to the food stuff when the fertilizer seeps into the actual food itself, or you are advised to wash it before eating it because of the residue. Okay, and then the fertilizer and the probability of the effect it would have on you. See, now that brings me back to, we're still, you know that cow things, what cows eat. Here we don't have a problem. They eat grass. When you go to some of these countries and you order meat, you can be asked, do you want grain-fed or grass-fed meat?
The Wagyu.
Yes, they do.
So you ask, what else do cows eat here?
True. They are fed on special feeds.
Yes, so those special feeds sometimes are a bit iffy. What I'm trying to say is the lack of clarity and an absence of an honest discussion into these things. When foodstuffs come into a discussion and somebody who has initiated the discussion has already inflamed the discussion, the truth about the subject gets lost. So now we take sides based on the emotions of the issue instead of the facts of the issue. Back to non-communicable diseases. You see, the argument has been, if you look at parts of the country, for instance, where people like drinking very, very hot tea, there are those who have suggested that esophagus cancer can be attributed, as I said. Yes.
That's a thing.
No, I'm saying what people say.
Okay. No, this is me being shocked.
Yes.
This is actually me being very shocked.
Yes, and when you look at even the spread of cancer, say for in a country like Kenya, they talk about areas of this country where there's a preponderance of the use of fertilizer. And the argument is this, that the fertilizer not only seeps into the plant, which is eventually the food, but also into the soil. So that entire ecosystem of the plant has fertilizer in it. This is the thinking. So that you are in effect consuming fertilizer.
Yeah.
And that may actually bring about
contribute to the cancer and other diseases.
Why a discussion like this is important is because we then get to talk about the reality of these things. Forget what you think. Forget what your 10 best friends have told you. So you they read or they saw this movie on the dark web.
It's a conspiracy movie. Yeah.
No, it's true what you're actually expressing. And I will tell you about fertilizers also, because I've taken a bit of some small interest. Again, commercialization.
Yes.
What is a certain product doing to our soils? City, look at it. Fertilizer in 1980. It is not the same fertilizer.
No, it is not.
And the question is, fertilizer in 1980 ilikuwa inachunga mchanga.
Yes.
Fertilizer ya saa hii haichungi mchanga.
Yes.
So what has happened? Why is it that we are not producing good fertilizer that is also taking care of our environment? So you find now, I will still give another example. Do you know dawas? Amoxil.
Yes.
Yeah.
Unajua kuna zenye ni unga.
Yes.
Eh?
Yeah.
Like aisaidi ama unamaanisha?
Aisaidi. Unaenda unameza hii dawa, unameza, umepea mgonjwa dawa. Ai, unashindwa kweli hii ni nini ilifanyika na hii aisaidiangi.
Is it because of antimicrobial resistance?
That's number one.
Okay.
But again, if you look at the aspect of the active ingredients and who manufactured this drug,
yes,
we are commercialized. We have commercialized the bit. Apart from instead of looking at the treatment and cure of patients in terms of diseases,
yes,
then somebody just sits down and says, Mbuvi na Katambo wako na bana, tuko na 100 million, let's make a factory for drugs.
Yes.
And then we start making some substandard stuff, or we add something if we are making fertilizer or something. And this is why I said GMOs are not bad. It is all about regulation. Before any drug checks in here, let it go through thorough checks so that we are very sure that when a doctor writes Panadol or acetaminophen for that matter,
yes,
which is the active ingredients, that even if it is made by 10 brands,
yes,
it is the same ingredients, same active ingredients,
same potency
in all the drugs. That is what is happening in the industry, in all the other industries. Because we have relaxed in one of them, don't think it has not relaxed on drugs.
Okay.
It has relaxed on drugs, fertilizers, foods, and everywhere. And this is now what we think, because there is no now regulation. For example, somebody has probably added a carcinogen. And I will tell you, the one industry that has really improved, and I'm not saying this so that people smoke, but in terms of prevention of when somebody smokes, unakumbuka kitambo watu walikuwa wana roll
tobacco na
hiyo. Now when you would add that thing, you would get millions of carcinogens.
Okay.
But now with time, because of super regulations, they have put a lot of regulations and the carcinogens have gone down and down and down. But remember, for the listeners, we shouldn't smoke.
Yeah.
But in terms of those cigarettes now having carcinogens, has really decreased over time.
There's a question here I have in regards to what you've just mentioned. Insulin. Is the insulin we have in the country legit? I know of someone who's been using a certain type of brand of insulin.
Yes.
And then when they changed the brand, suddenly their sugar levels improved in terms of the management of diabetes. Yeah. Is the insulin we're using in this country legit?
I would say it is, because most patients are on insulin, and the insulin they are using, it's working. Maybe for this particular person, there are many factors we'll look at, by the way. Before we say it is not working, look at the individual. And this is where City was saying, look at the individual first.
Yep.
How are they storing the insulin? How are they injecting the insulin? Because there's a way I can give you an insulin pen. Yes, it tends to be better because ukiitoa inaweza kawa 28 days. But again, if you expose it to a certain temperature, you denature the insulin. In fact, one of the treatment for somebody who is not improving on a certain form of insulin, maybe a certain dose or a certain pen, one of the treatment is to change to another insulin on another brand, and you will see them improve. That does not mean that was not working. You find maybe it's just a batch number, maybe it was an issue with storage, injection. So I wouldn't say the insulin is not working per se. What I know is that the insulin we are using here in the country, just like many other, some of the drugs we use for type 2 diabetes are not even being used in the Western world.
Why?
Because they are now we are using maybe 3rd generation and they are in 1st generation drugs.
Basically work on a better drugs.
Yes, better versions. It's just like I don't want to use
so
that.
ni tuko 3rd world tunatumia 3rd generation.
Actually,
because it's cheaper.
You can give an example of ARVs.
Yes,
the advent of ARVs, you were like a walking pharmacy. The number of drugs you had to take, research found that if you combined certain drugs, you would, instead of taking 4 drugs, you take 1.
Yes.
Which is a combination of some of the active ingredients in the other drugs. So you had the same effect. To the point where instead of taking 6 tablets in every day, you took 2.
Yes.
Okay? Now, that is research that has found that whatever you had has been improved on. You move from the tablet to an injection.
Yes.
And you're told you take this injection, a couple of months down the line is when you come back.
Yes.
It's an improvement. The active ingredient that was in the tablet has been improved, and you now have something else that is now in injectable form. And you don't have to ingest this. It is able to give you the same results, and you don't have that continuity of a daily basis. For 6 months, you will be fine. Now, that is how science improves. Specifically, since we're talking about medicine, that's how it improves medication.
Yes.
Yes.
Right.
Yeah.
Are there communities that are genetically predisposed to getting diseases such as diabetes?
Yes.
Because of their genetic makeup?
Yes. They are. And again, because of lack of studies, we do not really know in Kenya whether we have those communities. There is no one who has come out and really studied. But out there, but out there is some community that says actually you can go into some Asian communities, some ethnicities, some, like, what do I call them, tribes, that have been studied vividly, and we know them. In fact, they have even lowered their numbers in terms of when to suspect diabetes. They have a special definition that if you see, probably I don't know whether it is okay to mention Chinese, they tend to have a lower definition. Like, for example, if we say a BMI is 18 to 25, we say for a Chinese, if you are more than 23.5 or 24, I can't remember, but 23 or 24, then you are overweight.
You're very likely to get this disease.
Exactly. And now when you get to 28 instead of 30, then you are obese. You get. So they have studied that population and ethnicity, and they have even tailored, and they have a definition for their form of when we can say this community has a disease. But we never tailor that here. So we are studied with, among others, in the Western world. So utasikia, for African communities, we recommend. You see, we recommend, and they have done that. But in terms of now coming to Kenya, and even City the other day was asking, who studied, I don't know whether it is him who was asking,
it is
the BMI. It is something we adapted, and I agree, but now what do we do? Because that's what is available. There is no one who has come here and really done a simple study on all of us and said, maybe this BMI thing does not correlate with the African community or who we are. But then we just have to depend on what is out there. So in terms of communities and ethnicities out there, I know there are some that we know are predisposed to non-communicable diseases and their genetic predisposition has been isolated and we know them. But here iko shida.
Kuna mtu unaweza pima like this celebrity called Gen Z Goliath. Unaweza mpima mwambia ako obese na jamaa yuko obese.
Yes.
But if we use that BMI definition as is, then yes. Anyway, so that's that as far as Nini is concerned. But what I would like to understand then going forward, because I think this is what Kenyans need to know, and I can see that conversation also happening here on our comment section. How do we have a blueprint for losing weight, like one that we can say, because going to the gym doesn't necessarily mean that you lose weight, you know? There's this thing naskianga, calories in, calories out. That is more or less the baseline. What you eat tupatie your formula.
Let me ask you, how much calories do you need in a day?
I don't know.
2,500 as a man.
Okay.
But we take more. You've been to the gym, I assume. How many times, how long does it take you to burn 300 calories?
Again, I don't know.
On average, if you're on a treadmill and you're doing average walk, it will take you an hour. And maybe if you're doing 6 kilometers per hour, watu wengi wawezangi, maybe 5 to 6. On average, you should be able to burn at least 300 calories per hour. Sawa. How long does it take you for you to consume 300 calories?
A simple sitting, bana. 10 minutes ushakula.
Do you see why that theory is very hard to hold? Yes, I want to agree with you. Calorie in, calorie out. But how many people now can practically eliminate what they have just eaten?
What?
How many times have I gone to a gym and then nafika pale kwa gym, mtu ameingia kwa ka treadmill hapo 5-10 minutes, ametoka ameenda ameinua kachuma tuwili tatu. Even if you have even if you had a structured gym very well, which I recommend for a structured program, when you go there and you know exactly what to do, cardio, weight
leg
resistance, leg day or whatever, which is good. I love it because you improve your muscle, insulin, blood flow. It is beneficial. It's not that it's not beneficial, but when you come out, 80% of your disease called obesity is highly dependent on food. So if you get a good gym instructor, they will tell you, ni vizuri tukae hapa tuchape gym, lakini food is the biggest bit of every person. So you must be able to sit down and tailor what you are eating. Otherwise, you will be wasting time in the gym. In fact, I dare say, if you are going to the gym to lose weight, stop it. Because it doesn't add up. It doesn't. If you are going to the gym to lose weight, utapata mtu. Angalia January. Look at your circles. Watu wataenda gym wengi sana. Wataenda gym for 2 to 3 months.
New Year's resolution.
Look at how many kilos wata lose. Wata lose between around 5%. Kwa hivyo kama ulikuwa 100 kgs, 5 come to 95. All right? Mwenye atafanya sana atafika maybe 90. But let us now look at that population in 6 months time. Where are they?
Back to 100.
Exactly. Lifestyle if sustained is the key to weight loss. It is very important. Yes.
You know, there are some of these questions that we ask. The response is not necessarily direct to one discipline. You could be combining genetics to anthropology and just evolutionary biology.
Yes.
What do I mean by that? If you live in an environment where people just ordinarily walk long distance, that's what they do.
Yes.
Scarcity of resources and whatever circumstances. You will find that those people, by and large, are slender in frame.
Yes.
Because whatever they consume is utilized fully.
Exactly.
It is burnt in one way or the other. The physical activity that takes people to the gym is done. Again, if you look at what they eat, it will also tell you that the likelihood of you gaining unwanted weight is absolutely, should we say the possibility is limited.
Yes.
There are studies that have been done with communities that are referred to as pygmies, whether it's in the Amazonian region, whether it's Southeast Asia or in DRC. And there have been studies to look at the bodies of these individuals, and the argument has been is these bodies over time, over a long period of time, have adapted to the environment.
Yes.
Okay? So that when a body is smaller, the argument is what can it do? How does it respond to heat? How does it respond to humidity? How does it respond to food? See, all these assertions, okay? Because many of them don't live in the sort of houses we now live in. Okay. Everything about them has had to do with adaptation. That's why they live there quite happily. They've also adapted to the diseases that are prevalent in those particular places. Okay? But again, the honest discussion about what causes or what brings about the problems that we have is not something we like to hear.
Yes.
No. There's always some pop reasoning and pop psychology and pop science that is inserted into the discussion to suit, again, certain commercial interests.
Yes.
Okay? You can't have a gym if you don't have equipment.
That's true.
And the moment you start going to the gym, there'll be somebody who's telling you that when you go to the gym, you must drink this sort of thing, drink this sort of thing, and drink yes, they will.
Yes.
When you eat this and drink this particular mixture, then the likelihood of your body doing this and the other. So the world of commerce then plays a very, very important role on something that is quite significant and serious, and the commercial element is what we tend to interact with because it's in our face, and that is what forms most of our discussion. Because if you look at a basic villager in our country,
right,
for the longest time they were food sufficient. They were food secure.
Yes.
They planted what they needed, they ate what they needed. Some of us in our youth, even when we were in town, parents who worked for the government, you inherited a house that a colonialist lived in, so it had a compound. Our parents didn't grow flowers. There was a kitchen garden. They grew food.
Yes, they grew food uko inje.
So every evening when you wanted to eat, you were told to go to that kitchen garden, chuna mboga, take this and this to eat. So meaning they had been brought up that way in their time, so they brought those habits into town.
Yes.
Now, nobody does that.
No.
We all go and buy our food. Okay? Nothing wrong with buying our food. But because of the cost, there are people for whom food is still actually brought from the rural areas. It's transported. Now, what has messed up this whole equation is a motorcycle.
Yes.
The motorcycle, yes. It's absolutely revolutionary in many ways, even harmful.
Yes.
Because in the rural areas, we now have motorcycles, and you can go to places you couldn't go before.
Yes.
You don't have to walk long distances. You can take a motorcycle. But these are evolutionary what? Processes. Now, it's in understanding them and how they relate to our health. There's usually a gap there.
Yes.
And again, the commercial interests are what will occupy our minds because they are what we consume the most.
Yes.
Ukipata ukienda gym unapata na weed anakuambia bodo unajua itabidi sasa umeanza kukula nini kuku
That's a key. And that what City has mentioned is very important because in as much as we say diabetes and obesity is common in urban areas, in our rural areas it is spiking. It is really, really spiking. And the saddest bit to add into that is that sasa utapata the lack of information in those areas is, or ignorance if I might call it, is so high that the disease is spreading quickly. Because once then umenunua motorcycle, now you have, or you can now suddenly move from one place to the other. Now you can suddenly provide for your family. Now your family doesn't really need to work hard because maybe ni wewe na ndugu yake na nini wameweza kuprovide. So now we have slowed down. And then now what happens in that environment, kuna dispensary ambayo tukienda pale tumeanza kutapika, tumeanza maybe tumekuwa na kakitambi. If you go to rural areas by the way, umeona watu wangapi wakonda? Watu wamenona. Wametoa wapi kitambi? Si ati chakula hiko, but now how we are relating with food with our output in terms of activity has significantly over generation changed. And the resources to deal with that, especially with that in our environment here in Kenya, is significantly low. how then, if you go to the hospital, for example, I don't know whether I talked about the symptoms of diabetes.
Yes, you did.
Type 2 diabetes, I said, if the first sign of type 2 diabetes is lethargy, mimi nasikia tu nimechoka, nasikia concentrate yangu si poa, ukifika home unataka tu kukaa kwa sofa, ukitembea kidogo unasikia mimi nataka tu nikae. This is the number one symptom for type 2 diabetes. Before we can go all the way back to where now we were talking about, maybe now unasikia kunywa maji mengi, kukojoa, kukula vitu zenye ziko na sukari. This is the first time. But when you go to our local dispensary, let's say uko kwetu Water Town, me I come from Mwani.
Okay.
Na nimeenda Mwani, niko kwa dispensary, and then I present these symptoms to the dispensary person who is taking care of this. How many will think about diabetes? And even if they think, do they have a glucometer? Do they have BP machine? Do they have an HbA1c to diagnose type 2 diabetes? No. So there is late diagnosis in these populations. Now, late diagnosis in this population means more complications. Unanielewa? So it is not uncommon for people now to come to you when sasa anakuambia mimi nimeshindwa kukojoa, ama anafura asubuhi, anafura uso nini, mguu ilianza kufura, yeye alikuwa anafikiri ni kawaida.
That is now already advanced.
That is now already, and I will tell you, you are saying already advanced. This is how they present. Go to Machakos referral hospital, go to Wote, go to any place. Mpaka unajiuliza, where were you?
All this time.
Yes.
All right, Daktari, we have about a minute. I want to talk about your book, because you have a book,
Yes.
So before we leave, what is the book about?
I wrote this book in 2023, and this book is all about food. It is exactly what we have been talking about here. Why? And I call it Kitabu cha Sukari because I wanted to spread information regarding foods, especially localized foods. Now, when I came back, I gave that story and I said, look at it this way. You're telling me, and it was mainly to debulk myths. Because somebody would come, napata shosho ametoka Kitui ama Makueni huko kwetu, ame struggle. Anakuja ananiambia, daktari, mimi nakulanga chakula yenye niliambiwa nikule. Niliambiwa nikule nini? Viazi. Niliambiwa nikule ndoma. Niliambiwa nikule makwazi. Niliambiwa nikule mkate ya brown. Niliambiwa nikule
ugali ya brown.
Yes. But then now when I look at science, so yes, it is true, ugali ya brown has more fiber. All right? It does. So if maybe 100 grams has 15 grams of fiber, okay? And maybe 100 grams of white bread has 5 grams, okay? 5 grams. So I asked myself, so is this enough for me to recommend brown to white? When I now went into checking, I realized if you look at science,
yes,
if you're not careful, the brown ugali might have more sugar
than even the white.
I realized now when I tell somebody to eat fruits, because now you're telling these people who have diabetes, eat fruits, they are good. They give you vitamins, they have fiber, they have phosphorus, they have all this. And I said, it's true. We are not disputing this fact. But to what extent then do I eat these fruits so that if I am diabetic, they don't spike my sugars?
Okay.
And therefore I put maembe. So I put a maembe, for example, a mango. And I said, how much would maembe ya mololo, nice one, the nice big one, have in terms of sugar and the other content?
Okay.
That is what I put on this book.
Where can we find it? Yeah.
This book, you can find it in Afyacode, which is my company, afyacode.com, or you can call us when you look at all of us in our social media platforms. We also have branches in Naivasha now, and in Thika, and here in Fortis, and you can get the book there.
So there we'll get the calories and we'll understand what to eat at on that point. All right, there we go, folks. We're taking a short break. Thank you, Daktari, for that particular insight. We shall now call you again at a different time to talk about these GMOs. We need to educate our public on this, and we need to debunk some of these myths.
Yes.
Sawa.